Good morning once again, good afternoon or good evening from wherever you're joining us from. And you're welcome to our May edition of our monthly webinar. But this month we are celebrating the International Medical Physics Week, which is a worldwide program. And NAMP is celebrating it by having a webinar, which was organized by the Scientific Committee. So we have a lot to learn this morning, but before I go ahead and introduce our speaker for today, I would like to invite the chairman of the Scientific Committee, Professor Wojo-Egbe, who is here to just quickly give a few words, and then I'll introduce our speaker. Thank you very much. Professor Wojo-Egbe, are you here, sir?
Thank you so much, Dr. Yobosha, for the very beautiful beginning of our activities for today. All of you are warmly welcome to the 2022 pre-conference activities of the Nigerian Association of Medical. This conference is also deliberately organized to have international flavor. That is, it will really actually provide the opportunity for us to interact productively with our international colleagues. It combines two events, that is the International Medical Physics Week and also the Nigeria Association of Medical Physicists, that is NAMP webinars. It is this actually started, that is on Monday, that is May 9, 2022, and it runs through Friday, May 13, 2022. We specifically appreciate our colleagues, professionals, academics who participated in this event. Thank you so much, and we have benefited from it. Today, specifically, we want to listen to two webinars, one from NAMP and one from IMPW. I want us to really listen and take particular interest in the one that we are going to listen to from NAMP, organized by NAMP, and it is entitled Machine Learning-Based Computational Magnetic Resonance Strategies for Rapid Diagnosis of Coronavirus Disease, that is COVID-19, using magnetic resonance fingerprinting data. This is very, very important, basically, because magnetic resonance fingerprinting is a giant leap for precision medicine. Also, it looks at healthcare from totally different angle. Yes, it also presents the future of healthcare by magnetic resonance imaging. In fact, the future starts now. Please, let us listen to Dr. Michael Dada as he is presenting the webinar for the month of May 2022. You are welcome, Dr. Dada.
Okay. Thank you very much, sir, for that brief introduction to our webinar. So I'll quickly just introduce our speaker for today. As Prof has already mentioned, he is none other than Dr. Michael Dada, who is a very active member of the Nigerian Association of Medical Physicists and also an editor of the African Journal of Medical Physics. Dr. Dada is of the Department of Physics, Federal University of Technology, Minna, Niger State, and is also an international leading expert of computational magnetic resonance imaging for medical physics applications, and has been working in this field since 2011. Since 2018, he has led the Artificial Intelligence for Medical Applications research group at the Department of Physics, Federal University of Technology, Minna, and he has extensive expertise in teaching computational MRI at various levels and has organized many computational short courses addressed to the use of this MRI code in medical physics. Dr. Dada has actively participated in several international workshops and conferences and conference sessions dedicated to computational MRI codes applied to medical physics. And as I earlier mentioned, is an editor of the African Journal of Medical Physics. I would just like to add that MRI is not a very common area that medical physicists in Nigeria are actively involved in. Most of us are involved in radiotherapy, nuclear medicine, and diagnostic radiology. So it'd be interesting to see, like Prof said, another perspective to, the applications of MRI, nuclear magnetic resonance, MRI fingerprinting in medicine, and let's see how it goes from there. And I hope at the end of today's workshop that many of us will be interested in this field of medical physics. So over to you now, Dr. Dada. Thank you very much for being our special guest for this month's webinar. Thank you very much. And if you have any questions, please kindly put them in the chat, and Dr. Dada will be happy to answer them at the end of his talk. Thank you. Over to you, Dr. Dada.
Thank you so much, Dr. Yobosa. Thank you. I want to appreciate the ESCO, the organizer of this webinar, Professor Ujurugbe, and I want to welcome every one of us to this webinar. I hope you enjoy it. So can I share my screen now?
Oh, yes, please, you can.
Okay. Can you see my screen?
Yes, we can see your screen.
Yes.
All right, thank you so much. Once again, I would like to welcome every one of us. So I hope I won't bug you with too much details. So as I've been announced, the title of this presentation is Machine Learning-Based Computational Magnetic Resonance Strategies for Rapid Diagnosis of Coronavirus Disease using magnetic resonance fingerprinting data. So now from the Federal University of Technology, Minna, so in the MRI physics research group. So coronavirus disease is an infectious disease that has killed so many people. We see that since the onset of this disease, it has been so terrible for everyone. It doesn't matter how big you are. It doesn't matter how developed you are. We saw that COVID-19 caught every one of us by surprise. So every healthcare facilities were put under pressure. People were put under pressure. It had a lot of psychological effect on people, and it changed the way life is for everyone and for many years to come. So one of the challenges that we faced during this coronavirus disease has to do with diagnosis. How do you diagnose people on time? And this is not just the only problem. If you diagnose, you have to diagnose in such a way that you don't cause too much health risk to health caregivers. So how do you, for an infectious disease, how do you diagnose in such a way that you don't get too much other people infected again? So this was the major challenge that we faced. So as we can see, we saw that globally, as of 9th May, that's the day before yesterday. So we have about 515 million confirmed cases of COVID-19. So in which about 6 million people, more than 6 million people have died. So according to the WHO. So, and as of 8th May 2022, a total of 11 billion, that's about 11.5 billion vaccine doses have been administered to people to curb against new infections. So now we know that those who have been infected, a lot of people that managed to survive had different issues that had to do with the heart being affected, the lungs being affected. So now, apart from diagnosing this disease, the challenge of monitoring these patients after treatment comes in as well. So how do you do this in such a way in which you can do as rapidly as possible, so that you can sort of scan as many patients as possible? So now these are some other statistics that will help us in this introduction. We see that we have, as at new cases in the last 48 hours, about 383,000 new cases. We have cases, cumulative cases. The second column gives us the death. And we see that these are the number of people that have been vaccinated from coronavirus disease. Now, what areas of the body is coronavirus disease affect? So we see that the cardiopulmonary health is affected during COVID-19 infection. So it affects the brain, it affects the heart, it affects the liver, as well as the kidney. So it seems that this disease sort of target the most important regions of the body that have to do with our sustaining our health. So now we need to know how best we can diagnose this as rapidly as possible and as well as to monitor the disease. Now, what are the clinical challenges that we have faced when it comes to COVID-19? So PCR has been a very important modality for detecting COVID-19. So, however, we notice that using PCR to take this, testing kits are very few, so they are not enough to go around. So because everybody is sort of affected, so the testing kits that are available are not enough to go around the patient. So now, secondly, we see that even when you use some of these modalities, when you use some of these modalities, we notice that we have many cases of false results in which people who are COVID positive are diagnosed as COVID negative. So in that case, it's not just dangerous to the health of the patient, it's also dangerous to the health of both the family members and co-workers, because he thought is not affected, but we noticed that it was more or less like a mistake within the laboratory setting. So also, we see that PCR testing faces other challenges that have to do with mutations, such that we are experiencing currently, in which we have new variants, new cases. So when we have our method well suited to a particular genome, we notice that over time, this disease is sort of mutating, so it's changing its nature. So how do we match up with these changes? Now, we notice that asymptomatic patients too have been a very serious challenge to health, in the sense that when we don't isolate them because they didn't show any sign, but they are more or less like dangerous to the health of those who have not been infected. So now, lastly, we see that a lot of studies have found false negative results of over 12%. So which means that in 100 patients that have been tested, about 12 of these people were wrongly diagnosed. So this is a serious challenge. So now we notice that in terms of other challenges have to do with patients having multiple scans. Like, for example, like you have to have scans within 2 to 6 days apart. So one, this is slow. Then two, this puts like a limitation on the number of patients that could be considered for scan within a period of time. So it's not enough because it's not fast enough. So now we need to look for methods that will allow us to do like rapid diagnosis, in which a lot of patients can be taken at the same time or within a short period of time. All right, so we see that Nigeria, as an example of developing nation, they have reported a lot of lack of concern among the citizens. People are not going for testing. People are not going for vaccines. One of the reasons why we notice people don't go for vaccine is because there are a lot of apathy when it comes to, okay, what is the effect of taking the COVID vaccine? So we can actually monitor the number of people that are affected if they don't come out for testing. So now, also, we notice that when it comes to serological detection tools, then we see that we have low sensitivity. So that, okay, when they detect COVID-19, is this sensitive enough? So can we say 100% assurance that this patient is infected or not? So these are the challenges that we have faced. So to summarize this, we see that the basic challenge had to be with general testing and how we can do rapid diagnosis. All right. So, and we see that a lot of effort have been taken by international body, government agencies, but we as researchers still need to contribute one way or the other in order to address these challenges. All right. So now, what are the diagnostic techniques that are used for COVID-19? We have lung ultrasound. So this uses ultrasound to detect COVID-19. We have computed tomography, which we are very much familiar with within the country. Then we have chest radiographs. Then we have magnetic resonance imaging. So and we have positron emission tomography together with FDG. So now I would like to mention a little something about MRI. So it's not considered to be very relevant when it comes to lung disease, because for now, CT still takes the forefront when it comes to clinical diagnosis, especially when it comes to using imaging scans. So MRI can contribute to diagnostic pathways. One of the reasons why MRI is very important is that it's not just important for diagnosis, it's important for tissue monitoring. How do you monitor injuries that are sustained after the infection? The injuries that happen to the brain, the one that happen to the heart, the one that happens to the lungs. How do you monitor this in real time? So this is where MRI becomes very, very important, especially when it comes to cardiac complications. We see that most times it's not even COVID that kills people. It's because it complicates underlying disease condition that the patient have been living with for some time. So now what we need to do is, okay, we just don't want to diagnose alone. We want to be able to monitor how the tissues within the body of the patient has been changed by this infection, and how are they changing according to the treatment plan we must have applied. Now, one other problem that I've been encountered came from American College of Radiology, in which they categorically stated that chest CT, which is taking the forefront, has a limited role when it comes to diagnosis of COVID-19. Because CT cannot accurately distinguish between COVID-19 and other respiratory infections. So in order for us to be able to be sure, we must be able to have like something like deeper, something that could show us differences between COVID-19 infection and other related respiratory infections. So we see that it has to do with the respiratory system. So how do we tell that this is COVID-19 or it has to do with some other diseases? Now, also, a significant percentage of patients with COVID-19 have normal chest CTs. So for those patients, they are falsely convinced that they are healthy when they are not healthy. So they are involuntarily made danger to the society, because when they go around thinking they are healthy, so they can go ahead infecting other people without them realizing it. So now also, COVID-19 is highly contagious, as we know. So in order for us to use these machines for scanning, they tend to cause new problems to health caregivers. Okay, how can I be an health caregiver around a COVID-19 patient without getting infected? So these have always been the fear. Okay, and we notice that we are not just, we should not be just concerned about the health of the patient, but we should be concerned also about the health and also the mental health of the clinical health providers. So they are also must be monitored in a way in which, okay, in order for us to solve a problem, we shouldn't create new ones. So in most cases, we see that CT scanners have to be disinfected after every scan. So now what we are looking at, can we have methods that we bypass some of these challenges that we are facing? So CT scans and X-rays, they are not just recommended for diagnosing COVID-19. So we need, the recommendation is that, okay, other methods should be used together with CT in order for us to come to a conclusion. Now, if chest X-ray has limited role in COVID-19 diagnosis, the question now is that, okay, is MRI going to help? Can MRI help in any way? So one of the things we want to see now is that, okay, we want to see like, what is the difference in terms of findings between MRI and CT? We see that on FLAIR images, the upper intensity of the cortex and the bilateral olfactory bulbs with normal volume are being observed in clinical diagnosis. So, and what this means is that when it comes to magnetic resonance angiography, so this can actually be reviewed by monitoring the blood vessels of the patient. Now, in terms of CT, it has been observed that in acute cases, there are extensive hemorrhage with subarachnoid and intraventricular hypodensity. So these are the clinical observations that have been made. So which shows the uniqueness of each modality when it comes to COVID diagnosis. Now, MRI in COVID-19 diagnosis. So we see that cardiac MRI, which is the MRI of the heart, is a non-invasive method. So it doesn't use ionizing radiation. It's actually preferred because of characterization that it gives when it comes to myocardial tissues. And sometimes, but the risk of contamination of imaging facility makes this very, very challenging when in acute settings, okay? For example, like when we monitor the patient, okay, we have to disinfect the machines all the time. We have to monitor the healthcare providers that they are not infected as well. So we see that MRI is a bit better. So in terms of tissue characterization, but those challenges, how can we address them? For example, when it comes to contrast enhanced MRI, so this is what we meant by late gadolinium enhancement imaging. They show diffuse pattern involving predominantly some kind of unique distributions. So, and we see that these distributions must be characterized for us to be sure that this is according to our diagnosis. This is for COVID-19 and not some other respiratory problems. So dedicated protocols with rapid acquisition to assess ventricular morphology are currently being worked on. And this is a direction in which we are trying to tend towards. Okay, how can we obtain data as rapid as possible? So we want to obtain data very rapidly. So now, one other thing that we need to note is that decreased right ventricular ejection fraction, cardiac output, stroke volume, and all these things are all signs of COVID-19. So which means that COVID-19 does not just affect the respiratory system, it affects the blood flow within the body. Now, furthermore, it is important for us to notice this point, all right? So due to strict infection control measures, pulmonary MRI of COVID-19 has been very much challenging. So we also see that neurological manifestation of COVID-19 have been leading to all other problems, dizziness, anosmia, and some other stroke-related and neurological problems that we must be able to monitor within a very short period of time. All right, so now these are some other findings that have been made. Talk about upper intensity within the brain tissues, especially in the temporal lobe and thalamus. Then we see that some other patients have also demonstrated liver injury after infection. So now we need to know what exactly caused this injury. How does the infection lead to injury? So in order for us to be, we must be able to have let me say like a molecular fingerprint printing modality that could go deeper than what we see. All right. So now, what are the challenges in summary that need to be addressed? So the first one is like we must have safe and non-invasive imaging modality. All right. So we want that safe for the patient and the one that is non-invasive so that we do not cause more problem in terms of underlying disease conditions. Then we must be able to do quantitative characterization of myocardial and other tissues, okay, liver tissue, the lung tissue, the heart tissues, how can we quantitatively characterize their condition? Now, the third one is that, okay, we want to have rapid acquisition and diagnosis of this disease. I mean, data acquisition. Now, number four, like there's immense workload. Sorry, I still put 3 there. So there's immense workload on clinicians. They have to attend to so many patients. So when they are under pressure, they are likely to make mistakes. And the fear of getting infected can contribute to like psychological pressure, okay? I'm trying to save people's life. Now, what if I get infected and I don't survive this? Who is going to take care of my family? Who is going to take care of what I'm leaving behind? So you see that the clinical health providers too are under a lot of both physical pressures and psychological pressures. So now, how do we help? The last one is that we must be able to reduce the number of interactions between the patient and the clinicians, in order for us to reduce risk of infection. All right, so now, how do we address these challenges? So we hope that we can use computational magnetic resonance imaging methods and machine learning models in order to address some of these problems. Now, how do we do this? Now, what is magnetic resonance fingerprinting? So magnetic resonance fingerprinting is a new approach in MRI that allows simultaneous measurement of multiple tissue properties in a single and time-efficient acquisition. Now, for example, the scan we see in the clinical settings, they are as a result of what we call a spin motion. These are invisible particles within the body, the tissue water that move from point to point. So we see that when these tissues are interacting, so they tend to leave imprint on what we call T1 relaxation time. So the relaxation time carries information about what these molecular bodies are doing within the body. So they tend to know what happens before the onset of the disease, during the disease, and they can tell us, they can give us information of what happens after treatment. So what are the parameters that are normally used when it comes to MR fingerprinting? So we have T1, that's spin lattice relaxation time. We have T2, the spin relaxation time. We have the static magnetic field. I know some of us who are experts in the clinic, we must have dealt with 1.5 Tesla machine, 3 Tesla machines, 0.5 Tesla, 0.2. So all these 0.2, 1.5 Tesla, they are just the size of the static magnetic field, which we call B0 field. Then we have what we call proton density. So within the body, we know that more than 90% of our body is made up of water. Now, the water within our body is made up of protons. So which means that our body is full of protons. So these protons, we must be able to quantify their density in terms of MRI. So, and this is what we measure when it comes to equilibrium magnetization, which we call M0. Now, recent works have added more tissue properties that are monitored. We can have the radio frequency field, the transmit field inhomogeneity, which is B1. We have T2 star, which is actually very, very important when it comes to tissue susceptibility. We have perfusion that has a lot to do with blood flow and macrovascular properties. So I won't go into details because of our time. Now, when it comes to MR fingerprinting data, all right, all the data we use for this study, they are from this particular important study. So we noticed that this is a multi-center research made up of about 10 institutions. About 10 institutions work together, bringing all the data that have been collected so far. So as at the time we were doing this research, this work gave us one of the most comprehensive data when it comes to MRI. So I mean, when it comes to COVID-19 diagnosis with MRI and other PCR and other very important modality. All right, so now, when it comes to computational MRI, so our basis is like, okay, we want to look at the MRI physics. So the MRI physics, we tend tend to tell us, okay, if we want to do prediction of the MRI signal, we must be able to, okay, what will the physics look like? So this is for what we call Bloch NMR equation. So this equation is the basis of MRI. So we want to understand the physics, and we want to see how the response can give us like a profile of what is happening at the molecular and during molecular level during disease infection.
Okay. Yes, as I was saying, this is the basic MRI physics, which we call the Bloch flow equation. That's the Bloch equation that takes into consideration the flow of spin. So, and the parameters that have to do with MR fingerprinting have to do with the T1, T2 relaxation times, the M0, as we can see, D1. So most of the fingerprinting data are in this equation. So now what we try to do is that we try to solve this equation analytically to get an expression for the transverse magnetization. So the transverse magnetization is more or less like is quantifying our MR signal. So okay, now the definitions that are given below. Now, in order for us to simulate our the solution, so this data were taken directly from the work that I introduced to us a few minutes ago. So we have the cardiac MRI observation within the clinic, the left ventricular end diastole volume. So some other parameters. So this is what we call the cardiac MRI data. Then we have on the right-hand side, we have the hepatic panel test data. So the hepatic panel test was conducted on patients who had COVID and those that are used as control. So now we have some other data, this brain volume analysis data here. So as you can see, they are taken for Raman et al. 2021. So then the last one had to do with what called spin analysis data. So this specifically is very important because it takes into cognizance the T1 relaxation time, the T2 star, the volume rate index, and the normal volume rate. So for both COVID and in control. Now, what we did in order for us to get a data set from this clinical observation is that we took into consideration the number of patients that were observed. So for example, like in the case of COVID, I think we had about 58 patients that were taken into consideration, while the number of control was just 28. So now what we did is we developed a code in R that we use to randomly distribute this data according to the patient. So which means that what we use is actually what we call a simulated data. So since we do not have access to the observation for each patient, so we had no choice than to find ways of try to randomly distribute. Now, within, if you look at this data, we'll see that we have a lower and higher range. So which means that all the clinical observations that were made were within that range. So what we did now is that, okay, for example, when you have like 58 patients, so we now randomly distributed, for example, head size scaling or peripheral gray matter volume, according to the number of patients that were clinically observed. So from there, we were now able to get a data set for, this is for spin analysis. So we have for T1, for T2, according to the number of patients that were clinically observed. So we now computed T0, which is relaxation rate on our own. Then we computed the transfer magnetization signal according to the solution that we have to our differential equation. So the gender, we see we have like 1 and 0 there. So 1 represents female, while 0 represents male. So now this is for spin analysis data, which we are made into a data set. Now we now have cross-section of computed data for cardiac MRI. So some of these are our data. They're about, some of them are about 250 rows of data. So we just pick the upper part of it. So just for us to be able to see what was done. So we have the gender. Now the outcome, that's the response, is that, okay, it's either COVID or it's non-COVID. So now this is the cross section for computed data set for hepatic analysis. All right, so, and this is the cross section of computed data set for brain volume analysis. So we have done the same thing for virtually all the clinical observations that were made according to the number of patients that were considered. All right, so now in order for us to do machine learning for this clinical data, so we needed to try to perform what we call correlation analysis. Like, we want to see which of these parameters correlate more than the other. So now we see that our correlation goes from 0 to 1. So those that are close to 1 are well correlated, while those that are close to 0 don't have any relationship at all. So in order for us to do machine learning, we must know those particular parameters that are correlated so that we can use them when it comes to building machine learning algorithms. So this correlation matrix and scatter plot for the spleen data set. So now this is the correlation matrix for cardiac MRI data. So for infected patient and controls. Then this is the scatter plot showing how these parameters are related to one another. So then now this is the correlation matrix for the hepatic panel data set. So now, in order for us to understand more, so I think some of us, especially our colleagues within the clinic, will understand this particular illustration better. So this is a Pearson correlation for all the data set features that we have simulated. So we have for cardiac MRI, this is for spleen analysis. So we can see that this also goes from, this goes from -5 to 1. So we see that those that are well correlated are shown with unique colors, as we can see. So this is the Pearson's correlation for the features from hepatic panel analysis data set. So while the last one is for those of brain volume analysis. All right. So now now that we now know the features that are correlated, so we now went ahead to perform our machine learning programming. So the algorithm was done in Python. So, and for the entire data set, what we did is that 80% of the data set for each of those data sets were used for model training, while 20% were used for model testing. So as we can see, we have almost like about 12 classification algorithms that we tested on our data set. So the k-nearest neighbor, SVC, so that's support vector machine. So this is based on support vector machine. We have decision tree classifier. So these algorithms were used to test our data in order for us to know which one is going to give us the best performance. So the performance was shown here in terms of accuracy of our model training and the log loss. So how are they able to identify each of these parameters according to the outcome? Is the patient COVID infected or is it not COVID infected? So as you can see, we have put those highest values in bold here for us to see. We see that random forest random forest classifier can perform very well for cardiac MRI. So you return 94% accuracy. So now, but if you look at it in terms of general performance, we can see that decision tree classifier gave us the best effective result for all the data sets that were considered. We see that none of his performance was less than 88%. So it means that in 100 cases, 88 times, this algorithm made correct prediction. So which means that if we want to use this algorithm as an assistant to a clinician or to a doctor, in 88% cases, it will be right. So they are not always, like when it comes to machine learning, we do not emphasize that this machine are going to replace the clinicians or going to replace the doctor, but they can serve like an assistant to the doctor. So for example, if patient use machine learning to diagnose patient, machine learning can categorically tell you those who are not infected based on the data set that they have been trained with. So you can now recommend those few ones that looks like infected for a patient, for the doctor to see. So we see that, okay, instead of him attending to 50 patients, so he may end up attending to just 10 or maybe 15, which is going to reduce the time and pressure on him. Now, in order for us to understand this result, we have made a plot. So this is a plot of our classifier accuracy for cardiac MRI data. So we see that random forest gave the best result, but overall, decision tree classifier returned the best result. And we see that for the log loss, the ones that are close to zero shows those that had the best prediction performance. So they are able to detect COVID-19 with minimum error. So the other plot that we have on the other side has to do with feature importance. So we were able to ask the algorithm to compare each of the features in our data set and rank them according to importance when it comes to COVID-19 diagnosis. So which of these parameters is most important in terms of showing whether a patient is infected or not? So we see that for cardiac MRI, the LV, EDV, so that's the left ventricular end diastole volume, is the most important feature, followed by left ventricular end systole volume. So we see that this has to do with the blood flow within the heart. Okay, is it at systole or at diastole? So which means that these two features are actually very important when it comes to using cardiac MRI for COVID diagnosis. Then we go to the next one, which is spleen analysis. Okay, we look at the spleen of the patient. Okay, now what we see is that other boost classifier had the best performance, but decision tree is the next in terms of effectiveness. So our decision tree actually has the same performance here, and we can see the log loss. And in terms of feature importance, we see that the volume of the spleen. So what this is telling us is that COVID-19 affects the volume of the spleen within the patient. So now, whether the volume or the volume index, so this is just a derived properties when it comes to the clinical observation. So you see that these two features are actually the most important when it comes to ranking parameters for spleen analysis. Then we go to hepatic panel analysis. So we see that here, decision tree classifier actually returned the best result. So every other classifier classification algorithm follows that. So this is the log loss for the hepatic analysis. Then we see that the most important feature is the total bilirubin measurement and ALT. So if all these abbreviations are defined within the paper I showed us earlier. So then we go to brain volume analysis. When we look at the brain volume, can we get something out of here? So we see that for this particular one, random forest classifier gave us the best result, followed by decision tree classifier. So now, and in terms of feature importance, we see that head size scaling is the best feature to focus attention on when it comes to brain volume analysis. So what this feature importance has shown us is that when it comes to diagnosis, this algorithm can actually serve like an advisor, okay, based on the data that have been considered so far. These are the features that I have seen to be most important when you are using this particular method for COVID-19 diagnosis. So the doctor can focus more on those particular parameters. Now, after this, as I mentioned before, we decision tree classifier return the most effective, the best effective result for all the data sets that we consider. So now we picked this decision tree classifier to build an app. Like we have like we call this deployment. So we deploy our machine learning algorithm. So that's the decision tree classifier to test how this could be done in laboratory setting or in clinical settings. So these are the apps that we have developed. All right. So now the first one had to do with the spleen analysis. So the second one had to do with cardiac MRI observation, while the third one is volume analysis, that's brain volume analysis observation. Now, hepatic analysis, we didn't do deployment for that, but we are currently working on that. So now, because of our time, we may want to test this on our own. So these are the links for us to the apps. So we can just click on this link, put our observation there, and see how our algorithm performs. Now, in conclusion, we have demonstrated how computational MRI and machine learning could be used for rapid and improved diagnosis of coronavirus disease. Now, as we have shown, magnetic resonance fingerprinting approach is not only important for COVID-19 diagnosis, but it's also important for patient monitoring after treatment and further in vitro exploration of diseases. What I mean by this is that apart from the diagnosis of COVID-19 and monitoring patient after treatment, we can actually use this method to explore the disease more. Like, okay, we can take samples like a swab, put it in a test tube, then we can run in a typical MRI relaxometer. It will give us T1, T2 relaxation times. So with this, only this one, we can use it to perform our diagnosis. And one other thing I would like to mention is that you don't need to be there. The implication of this method is that we can actually teach patients to take samples on their own. We can take samples in their home so that they don't have to interact with a clinician or a doctor. What they do is that they just take swab on their own, then put them in a test tube, seal it up, and send it to the doctor or send it to a patient to our analysis center. So where a more robust form of this app can be used to, you take measurement, then you run the analysis and you get the patient condition. Is it infected or is it not infected? You don't have to interact with the patient at all. So what you just need to do is to get the sample from the patient, run the analysis. We can actually even find ways of introducing what we call Internet of Things, like IoT. So where you don't even have to send the samples to a physical doctor, a physical clinical scientist. So what you just need to do is, for example, we just have a center where you take the samples to, put it somewhere, you understand, for the sample to be read or to be analyzed. Then we can set up a lot of internet connection, and some other things for those data to be transferred automatically to the analysis side, where the analysis will be done. And your result could be delivered to you via email. So everything could be automated in such a way that interaction will be minimal. So this will reduce the risk of healthcare givers getting infected or being put under too much pressure. All right. So the third one is that this study has demonstrated that AI-assisted diagnosis could be done with low computational resources. I'm so sorry once again. One of the reasons why my computer trip off is because of the Python program I was running. So the Python program, when it's running, tend to put pressure even on the system. So now, and this is just a numerical analysis that we are performing. So, and if the system are under pressure because of numerical data that are used for doing the machine learning algorithm, you can imagine what will happen when we have to use imaging data. Like you have to use a typical CT scan or typical MRI scan to perform deep learning or maybe like AI-assisted diagnosis. So all this analysis takes a lot of computational resources. You have to have your RAM has to be big. You have to have GPU in order for you to even be able to do some of this run this algorithm. So what we are trying to say is that this particular method can be used in cases where our computational resources are not that significant. So then the last one is that the data we have used for this study are quite small, like I mentioned. So we just used 58 cases of COVID-infected patients and 28 controls. So, which is actually very small. And we can't say that this is representative of a typical population. So it will be very, very important for this algorithm to be tested on a larger data set, like taking into consideration like national biases, race biases, and some other things that can be put within the algorithm to make it as complicated as possible. So the more complicated our algorithm is, the more they are able to take into consideration every possible scenario. So this has shown to us that this is possible and that we can find ways of doing this no matter in a small way. We don't have to start big. We can start doing it small, you understand, in our own way until we have access to improve computational resources. Acknowledgement. I would like to thank the head of our group, Professor Bamidele Awujirogbe, who supervised this work. My thanks also go to Dr. Oduna Anasodo for encouragement. I would also like to thank the president of National Association of Nigerian Association of Medical Physicists, Professor F.A. Balogun, for encouraging us to make this presentation. And I also like to appreciate Dr. Yogusa for putting us under pressure until this is done. So I want to appreciate Mr. David Shaba, who actually helped out with his own personal computer for us to complete some of this algorithm. I'd like to appreciate Mr. Henry Sonny, who work mostly on this algorithm. So he spent sleepless nights developing the codes and perfecting them. So I want to appreciate Mr. Nicholas Udeme, who also assisted in this process, as well as my other student, Mr. Husseini Ahmed and Mrs. Jamila Suleiman, who actually assisted in getting this job done. I want to thank every one of you. Thank you so much. Thank you for listening. Thank you.